we were using or during week 1 and week 2. During week 1 and week 2, we cover the business side of medicine, and week 2 was more of medical terminology. On the CPC exam, this particular section will be entitled The Business Side of Medicine, and you'll also have a section entitled Compliance. So when they're talking about the business side of medicine, we're going to focus more on the payers. And when I say payers, I am talking about insurance companies. And so again, this is kind of like a mini review of everything that we covered during the span of the last 16 weeks, right? So of course, self-pay is going to be people that pay themselves or out of pocket. And as far as commercial insurance, there's only a few mentioned here. We know there's plenty of commercial insurance carriers. The ones they have here: Blue Cross, Blue Shield, Aetna, Cigna. The one I'm going to say that you guys need to make sure that you pay attention to is really going to be your government payers with Medicare and Medicaid. Most of the questions that they will ask, if it's in reference to an insurance company, will be in reference to Medicare. Okay, so just remember that, the Medicare. And just remember what the qualifications are for a Medicare recipient. So again, this is turning back in your textbooks. This would be covering Chapter 1, right? Chapter 1. And remember, we did our little quizzes with Medicare Parts A, B, C, and D. Part A is going to be for your inpatient hospital care. Part B is going to be for outpatient, or I say ambulatory. Okay, anything that uses Part B Medicare is going to be ambulatory, meaning you're not sleeping there. You're going to go get your service and then you'll leave that same day, right? That's going to be outpatient. Part C is your Medicare Advantage. And again, Part C is someone that has their Medicare through a commercial carrier, such as the ones mentioned above: Blue Cross, Aetna, or Cigna, just to name a few. Humana. United Healthcare is a really big one, right? Because they have AARP, which is a supplemental insurance. And then Part D, Medicare Part D. Medicare Part D is basically your prescription drug coverage, right? And remember, for Part D to kick in, the recipient or the beneficiary has to pay at least $5,000. I don't know if it's changed, but when it was first introduced, they would have to pay $5,000 out of pocket before Part D would start to kick in. Now, as far as what you need to know for the business side of medicine, just make sure you understand Part B. So when they're asking a question, they're going to see if they can test your knowledge to see if you understand what Part B is all about. And just remember that Part B Medicare is going to cover all of your outpatient procedures. So even if, or the procedures that are reimbursed, that's how the providers, the doctors, are reimbursed. Hospitals are reimbursed by Part A. And with Part C, some of you may have remembered me talking about Hcc coding. This is basically how Part C carriers also get part of their reimbursement. They come up, or they establish a cost that they believe would be used to treat a particular patient with a particular condition. And if they are able to treat that patient based on that projected cost, if whatever's left over is able to be divided between the carrier and the insurance company. So that's how the third parties, the Part C carriers, are also able to make and save money. And all of the forecasting on what it's going to cost to treat these patients is done through Hcc coding. Just remember that's going to be Hcc coding doesn't involve any CPT. It's basically based on what the cost that is going to take to treat the patient and the patient's diagnosis. It's based on ICD-10 code. So there's no CPT codes here. So if you didn't get any attachments, it's because you're maybe in my current class and we will be going through this again. So basically what you're doing at this time is just listening to the presentation and making the notes in your CPT as we go along. Okay. So the RBRVS over here, this is not something that you're going to have to be concerned about. It's a predetermined calculation of how much is actually going into treating that patient. And this is the formula that they use to reimburse the provider, reimburse the physician. So the RBRVS stands for Relative Base Resource Value Scale. Like I said, they're not going to question you about it as far as how to complete or come up with the formula, but this RBRVS, what I want you to know is what it's used for, and this formula is basically used to determine how the physicians are going to be reimbursed. Okay, so just going down here to page 2, and I'm also recording this, right? So I can send the recording to you guys too, so you will have it to view. And of course, you will be able to see the PowerPoint at that time too. Okay. Medical necessity. If I had an opportunity to go through this whole 65-page document, I would say that I would highlight my medical necessity in red, and they would be some stars next to it because you need to know what medical necessity is all about, right? So medical necessity, as it states here, are services that supply or things that are going to be needed to diagnose or treat the patient. Okay. So basically, medical necessity is if this patient is, what's not considered medically necessary is if someone comes in and they're coughing and they have chest pain, and then the provider decides to do like an x-ray of the knee. That is not medically necessary, right? But if someone fell and possibly fractured the knee, then yes, it would be medically necessary to provide an x-ray at that time. So basically, they're just making sure that you meet the standards and that we're just not blatantly just billing when it's not necessary to bill those particular charges or services, then it's considered to be fraud. So just make sure you understand medical necessity, or medical necessity may be a term that you need to write down, and make sure you get a full synopsis and understanding by reading chapter 1 in your PMCC textbook. Okay. Also, we have national coverage determination. We spoke about that a little bit also in week 1. This is also covered in your week 1, chapter 1 in the textbook. And national coverage determination basically lets you know whether Medicare is going to cover a particular diagnosis and the claim when it comes over, right? For example, in the week 1 PowerPoint, it explained, for example, they had the patient coming in for the vitamin panel essay, and it had to show what conditions or what diagnosis codes make that panel payable when we bill it, right? So if it was, you can't just bill it for a screening, the patient had to have a particular condition to support that CPT code for reimbursement. And if you need to know what the requirements are, you would go to your local MAC, which is for us, it's going to be Cahaba GBA, and you would enter in the CPT code or the test, the panel code test, whatever the test would be, and then it would let you know, or it would let you know what the payable diagnosis codes or ICD-10 codes would be. Okay. All right. Does anyone have any questions for me so far? Right now, this isn't the part you should be really concerned about. It's going to be coding. I mean, everything's important, but everything that I'm talking about right now, you just need to make sure that you're comfortable with. ABN, Advanced Beneficiary Notice. Okay, just remember that first bullet point that's in orange there. Providers are responsible for obtaining an ABN prior to providing the service or item to a beneficiary, right? So what are we talking about? I like to use the examples of lab test. For example, you can have a lab test and it may not be covered by the provider's practice. And so we tell the patient, hey, we're going to provide this lab test, and it's a possibility that Medicare is not going to cover this particular service. In the event that Medicare does not cover it, you are going to be responsible to pay for these particular services. That's what an advanced beneficiary notice basically is. The only approved form is the CMS R131. But what you need to be paying attention to is what that form is really about, what it's all about. And that's basically letting the patient know prior to a particular service being provided that it may not be covered by their carrier. And if it is not covered, then the patient will be responsible to make payment on that particular service. Okay, the ABN. Hipaa. Hipaa, to my right, slide 10. Hipaa, Health Insurance Portability and Accountability Act of 1986. That's the national standards for electronic healthcare transactions, and also how they submit the actual data to the payers. Okay, a long time ago, depending on who the payer was, they would have their own rejection codes. Now that everything is electronic, the rejection codes have the same meanings across the board, whether it's coming from Medicare, Blue Cross, Cigna, United Healthcare. A PR1 is still going to be unable to identify member or unable to ID patient. Years ago, PR1 may be unable to identify patient for Medicare, but Blue Cross would have like a B4. So they would have different codes. But now with Hipaa and the national standardization of everything, it is the transmission of electronic data has to be consistent across the board. And so now all of the payers have the same rejection codes with the same definitions and meanings. Okay. High tech. We spoke about high tech. And again, that's something I think that once you're done and you're successfully past the CPC certification, you definitely want to look into something where you can gain certification in health information technology. Okay. They really won't be asking too many questions about it, but you know that the Health Information Technology Act is to promote the adoption of meaningful use. Okay, remember what meaningful use is? Does anyone remember what meaningful use means or what that's all about? No? Yes? Maybe? Okay, so remember, meaningful use is just, I'm going to use the cell phone as an example. So if you have 15 things that your cell phone can do, we know you can go to the calendar, you can take recorded notes, you can send emails, you can send texts, you can check your messages, you can set reminders in your calendars. I think we can name more than 15 things, right? So meaningful use means the government put into play the HITECH Act, and this is how providers were being reimbursed for adopting electronic or health information technology, the actual system. For now, let's see, they have Epic, they have Cerner, they have McKesson, they have eClinicalWorks, just to name a few. But let's say they could do these 15 things. In order for those providers to be reimbursed, they have to consistently do at least 10 out of those 15 quality measures to be considered for reimbursement. The whole thing is just to promote providers entering the information and utilizing the capabilities that the health information technology tool or Epic or Cerner or McKesson, all of the capabilities that they have is to make sure that they're utilizing those so that they can pull great data reporting. Okay. And also, if you're in Florida and then you move to New York, to be able to exchange that information from one place to another. Within a workplace, it is important that all workplaces that are healthcare related that are touching claims have an effective compliance plan. Now, you don't need to know each of the steps of the compliance plan. What you do need to know, however, is there is at least 7 effective steps that compromise an effective compliance plan. At least 7 steps. All right. So that was a little bit, let me just go back up here for a second, just talking about the business side of medicine. So they can ask questions from any of these areas: high tech, how many steps are needed for effective compliance plan. You're going to say 7, right? Or they may ask about Hipaa. The main thing you need to remember about Hipaa is that it's national standardization for electronic claims, healthcare information, transmitting that information securely. It's all about privacy, right? And then we already know about your ABN, the Advanced Beneficiary Notice. There's a form that the patient's going to sign prior to the services being rendered to them, letting them know that the insurance company may deny the service, and if so, that the patient will be responsible. Okay, let's see what we got up top. Medical necessity. We spoke about medical necessity. National coverage determination, right? So they'll be covering over their jurisdiction. For us, it would be, I think it's 99 and 01. So they have Atlanta, and then they have the rest of Georgia on how we break up our region here. And Medicare Part A, B, C, and D, more than likely, they want to make sure, like I stated before, that you do understand the differences between A, B, C, and D Medicare. And then we spoke about the payers, knowing which ones are government, which ones are commercial. So we know our government payers: Medicare, Medicaid, TRICARE. Alrighty. So I'm just going to move on into the good stuff. Well, I did want to, ICD-10 I'm going to save for our boot camp, because I want to make sure today I said I was going to go through Integumentary, through digestive. If I get to cover those, then we can come back to ICD-10. How are you guys feeling about ICD-10 and sequencing? Anybody? How are you feeling about ICD-10 and your sequencing? Oh, wait, did I mute everyone? Okay. All right, I think you guys were on mute if someone was talking. Everyone, Nikki says okay, she's good. Everybody else? As long as you read, you know what, that is so right. And that's where we, well, we know when it's test taking time, we don't have time to, play around. We will be reading. You will be reading really closely. All right. But just to remember your 10 steps to look up an ICD-10 code, I have it listed here. Right? You got to make sure you're looking for the documented diagnosis. What's the condition, right? What does this patient have? What does the provider say the patient was diagnosed with? That's what you want to highlight. So, or you look for the main term, and then you would go to your index, verify it in the tabular. You would look right below it or at the 3-digit category to see if there's any further instructional notes. Okay. I did notice that most people are okay with ICD-10. I definitely will be going back into that during the boot camp, but I just want to make sure that you guys feel comfortable. But like Shonda just stated, just make sure that you're reading before you select your answers. All right, so let me just come over 10. They had a few little examples here, but these are easy ones, right? It's when they have those big questions. Okay, so this particular slide here, number 38, is just basically talking about how the CPT is set up. They're talking about the CPT, the guidelines, HCPCS, and level 2 modifiers. I do want to touch back on HCPCS. I know you guys know how to use the CPT, so I'm not going to go through what the symbols mean and that type thing, because these are, you guys went through my class, so I already know that you know what these are. I don't want to waste time on that. Talking about the symbols and add-on codes, those type things. So you can see why this is like a thorough overview. Right. So yes, someone asked, are we going to be able to have class? I don't know if it's going to be physically in the classroom, but you will have another webinar. You may have to do, we may have to do our boot camp online, but testing definitely will be in the classroom. It has to be. Okay. I hope that was your question. Not sure. But we are having classes right now because your classes ended a couple of weeks ago, but I just wanted to squeeze 2 more in and then do the boot camp for you guys. All right, so this is just talking about the setup. And again, they're talking about RBR-VS right there. So you can, again, it's based on the physician's work and how much is actually going into treating that patient and also the insurance. All righty. All right. If you guys just wanted to make sure that you understand how to use your HCPCS book, I know we've gone through it before, but I just want to make sure you're understanding and the places that need to be tabbed. Anybody remember the areas that I would like you to tab in your HCPCS? If not, I'm going to type them in the chat box, because remember, you're going to have maybe about 5, or I think it's only 5 HCPCS questions. And although it's only 5, those points will count, and those should be easy points, so I don't want you to miss them. So you need to make sure, and I'm typing in the chat box, the table of drugs, your modifiers, the index, G codes. And we say G codes because anytime it's we're talking about Medicare patients, your answer is going to come from the HCPCS book, and that answer needs to begin with a G, as in Geneve. Okay. Let's see. Am I missing anything else? I got the table of drugs, your modifiers, the index, your G codes. I think there's table of drugs. We already got that. Modifiers, index, and G codes. Alrighty. So please make sure that you have those areas tabbed in your HCPCS book. And depending on who the publisher is, it may be set up a little different. But just remember, if it's a screening, if let's say they're coming in for a screening colonoscopy, okay, remember that colonoscopy is actually a procedure, right? But if it's a screening colonoscopy, you can actually go to the word screening. You can look up screening in your HCPCS, and then what type of screening, and then it would basically be a colorectal screening, right? Because they're doing a screening for cancer. Or if it's cervical cancer, it's still a screening. Once you hear the word screening, that would be the term that you would look up in your HCPCS, and it's just like your CPT. It's going to give you a code range, and then you would turn to the codes. And you want to make sure that you have your G code section tabbed. Okay, G code. So G is for Medicare, and also on this slide they have H codes, right? H codes are for Medicaid. H. So they may ask what section or what does this HCPCS code begin with, used by state Medicaid agencies, okay, or by Medicare. So you need to know G is for Medicare, H is for Medicaid. All right, so let's move on. Anyone have any questions about HCPCs? Okay. And also on that table of drugs, just remember that you're looking to see, I'm trying to get to one of the pages here. So if you have it in front of you, you can also turn to the same. Okay. All right. So if I was looking, I'm just looking at my table of drugs right now, and I'm looking for the drug acetaminophen. And when I get there, it tells me that my dosage for acetaminophen is 10 milligrams, and it also gives me my HCPC codes. But if the provider orders 30 milligrams, what I just need you to remember is whatever that HCPCS code is going to be, it's going to be times 3. Okay, so just remember, times 3. Or make sure you multiply it by the amount to equal whatever is being requested in the question. Okay, so we're all good on HCPCS. Let's see. And again, remember, I will touch on that again when we get to the boot camp. Modifiers. They only got a few of them here. And remember, when you're taking your test, anytime you see a modifier at the end of the question, you want to look and make sure you know what that modifier represents, so you know what you're looking for in your question, right? For example, modifier 22 that's listed here is for increased procedural service. So it could be something that usually takes 30 minutes, but because of extensive obstruction, the provider then decides to do an additional 30 minutes. That's going to be increased, right? So if I saw 22 at the end of a CPT code, in my question, I better see something stating that it took longer than usual, right? So what happens is that the modifiers provide you with clues on what you need to look for in your question. And that's why I like when codes have modifiers. For example, I can tell you, you're maybe going to see questions with modifier 57, modifier 25, 58, 78, and 79. Right, so 58, when would I use modifier 58? 58 is going to be used, for example, remember that's a staged procedure. So someone could have had like a breast surgery, and then they're coming back to have like a tissue expander or the implant itself inserted. Right, so if they're coming back to have like a tissue expander or implant, they'll have 58 on that CPT. So you know that it's staged and there's going to be another section or something scheduled to happen to that patient. That's how they notify the insurance company so that they will not deny it as being duplicate. Modifier 57 back on the left-hand side. Modifier 57 does not go on a surgery code. Okay. Modifier 57 is basically going to be on an E&M code, right? Because modifier 57 means decision for surgery. They have not had the surgery yet, but they will have the surgery within 24 hours, right? So usually you'll see modifier 57 appended or attached to an E&M code, because E&M codes are office codes, right? So they go to the office and the provider's like, oh, you need to get those appendix out, and the patient's in excruciating pain. So on that office visit for that day is going to be modifier 57 because he's sending her straight to the hospital, or she will have surgery tomorrow, the next day, within 24 hours. That's what that modifier 57 represents. So please remember that 57 for test taking purposes is usually attached to your E&M codes, not to surgery code. They're already having surgery. So we're not going to say they're having surgery, decision for surgery. That doesn't make any sense, right? But you can say decisions for surgery once that patient went into the office, like an office setting. So that's just a little bit about modifier 57. So if you see modifier 57 attached to any code, any CPT code other than 99, you may need to read it very carefully, right? Sometimes they'll try and not really confuse you, but test your concepts to see if you understand the concept of how to use modifier 57. So they may have modifier 57 linked to a surgery code, or they may have modifier 57 linked to an E&M code. But you will cross out the two surgery codes and then decipher what's going on with those E&M codes if there's a level. Maybe it'll just be one and you'll be all done, hopefully. Okay. Let's continue. So that's talking about modifiers. Remember you have modifiers on the front and side cover of your CPT, and you also have a full description of all the modifiers in Appendix A, as in apple, towards the back of your CPT manual. All right, so here again, they're just talking about modifiers, different modifiers. You got 50 for bilateral, right? Meaning on both sides. Remember, guys, in the CPT description, if it already states bilateral, you do not need to append a modifier 50. It's like you're saying it twice. So if it already states that the procedure is bilateral within the CPT text description, you do not need to append modifier 50. However, if it's an example, and this is going to happen a lot, like in the 30,000s, like in the procedures on the nose and so forth, like that, accessory sinuses, where procedures can actually be performed on one side, which is unilateral, but in the question, the provider says bilateral. So you know that you're going to need to append modifier 50 in that particular instance. Modifier 51 is for multiple procedures in the same area. And modifier 52 is reduced, right? And 53, discontinued. You're going to see those two pop up a lot when we get to the digestive system. 52 and 53. Remember 53, how can you remember 53? 53 is like hemorrhage, right? So you have to stop if someone's hemorrhaging. Opposed to modifier 52, where it's usually a bilateral procedure, but the provider only chose to do it on one side. Now it becomes reduced, right? Now it becomes reduced. And modifier 59, very important. One of the indications you'll know to append modifier 59 to a procedure is next to the CPT description in parentheses, it usually states separate procedure. It will say separate procedure. What does that mean? Meaning it's not usually a procedure that's performed with another one. It would be considered integral of that major procedure. So that's why it stands alone. Modifier 59. Okay. Any questions? Because you know I can keep on talking. Right. Modifier 59 last year, I think it was last year, they came up with some additional, because people like to append modifier 59 onto every claim just so it can slide through the system for processing. So they came up with additional descriptions for that one modifier, because modifier 59 is very vague. So they introduced a couple other subsets of modifier 59 that explains other services. They will not ask you about these, but I do want you to understand that there are additional subsets of modifier 59. On the right, for the modifiers, you have modifier 63. That is for procedures performed on babies less than 4 kilograms. 76, important, repeat procedure by the same physician. Yeah, that's what's important. 77, another physician. So just make sure you highlight those two. Okay. 62 and 66, 80, 81, 82, those are modifiers that you may see in the nervous system, because usually it takes more than one surgeon to perform surgeries or procedures on the spinal cord or somewhere where your back has to be open and exposed, they're going to need more than one provider to help assist with that particular procedure. So usually in the nervous system, modifier 62 to surgeons is a common one, and also 80. And if it's really highly complex, they'll have a surgical team. Ancillary modifiers, this is going to maybe to deal with your 70,000 codes. That's radiology, all right? You see that they have modifier 26 and modifier TC. 26 stands for professional component. That is when the provider is actually reading the results of the actual test. And modifier TC is the hands-on, like a technical school. You're actually performing whatever that procedure is, right? So if a provider owns the equipment and he reads the results, then it is going to be considered global because he did both parts. He did both parts of it. But let's say the provider does not own the equipment and he sends the patient to the facility to have the test performed, then the facility will bill the same CPT code and append TC at the end, and the provider will bill the same CPT code and append modifier 26 at the end. So what that claim is now saying is the hospital performed the actual hands-on and the provider read or interpreted the results after the actual procedure. If the provider owns the equipment and it's in his facility, so what's important when you're reading questions from the radiology section, you need to make sure, where is this taking place? Is it at the provider's doctor's office or is it in the hospital or the facility? If it's in the provider's office, more than likely you're not going to need to append a modifier. It's going to be global, right? Because he's going to perform the work and he's going to interpret the results. So there's no need to append a modifier. The TC modifier gets the greatest reimbursement at like about 75%. And then for the provider to just read and interpret the results, that's going to be modifier 26. That's going to be the additional 25%. But if the provider owns the equipment, reads and interprets the results, it's considered global, and then he gets 100% of that reimbursement. Over to the other side, laboratory modifiers. These are all, you may see these when you get to the 80,000s, remember, path and lab. And so 90 and 91 are maybe going to be the ones you need to pay attention to. So when I say pay attention to, make sure you highlight them in your book. Make sure you understand what they mean. It's not like you have to retain it. You just need to know where to find it when it's time. Modifier 90 is outside lab. It's used to bill for lab services purchased from an outside lab, right? So I can say Quest is going to do all of my HIV testings, right? Modifier 91 is not, just remember, modifier 91 means that they need to have more than one test on a particular specimen. Repeat procedure is not because there was something wrong with the specimen, but because it was required. That's why they have modifier 91. Okay. And modifier 92, I don't believe they'll ask this, but it's just alternative testing. You know how sometimes they'll send the test home with you and you'll complete it and send it back. It could be a BC specimen, or they call it a smear, or HIV testing, right, where you just do a saliva swab and send it back off. That's called alternative lab platform testing, other than coming in to the actual laboratory or provider's office. Alternative testing. And then you have a couple modifiers for anesthesia, right? Modifier 23, unusual anesthesia. 47, that means anesthesia was administered by the surgeon. and your physical status modifiers. And of course, we'll get back into that when we do cover anesthesia. But remember, your physical status modifiers is to explain the condition of the patient at the time of surgery. And those physician modifiers range from P1, which is a normal healthy patient, all the way to P6, where the patient is brain dead. Now we're getting into integumentary. So since I just covered that, modifiers, anyone have any questions, or does it all sound familiar? I hope so. I hope it's familiar to you. What I want you to do right now, you should have your CPT book in front of you, right? Because we're getting ready to dive into the integumentary system. And so whatever you did not capture during class or when you're reading, let's see if we can capture that now. And that will be great, because then by the time we get to the boot camp, you should have everything in your books. So right now you should have your CPT. Anyone have any? Let me open up the lines because no one's talking to me. Anyone have any questions whatsoever?
No, ma'am.
No, ma'am. We're like, let's keep going. This is okay. All right, no problem. Okay. All right, so what page are we on? Let me just get in here. So right now I'm in my 2016 CPT, and I am on page 69. Page 69. So 69 starts the integumentary system. And you know what else is good on this presentation? Because remember, I have no idea what you're going to see as far as anatomy, right, and physiology. But I do know that they pull their content from what we discuss, right? So if you have this up and you see things like we're talking about integumentary now, and you can see they have anatomy of the skin, right? So there's going to be anatomy. What body system is it going to be on? I have no idea. So for me, while I'm in my CPT, if I'm looking at this presentation, I'm in my CPT, I'm on page 69. I see that page 68 has a half empty page, maybe not that exactly half, but the space there, right? I could put epidermis, dermis, subcutaneous tissues, or the 3 layers of the skin, right? Which ones has the blood? Do you see it? Do you see where I'm going? So you can have epidermis is my top layer, 4 to 5 layers. These are just things, or you can write next to the image that's on page 69. You need to have everything for integumentary in the integumentary section, right? You don't need to really write down chapter 2, chapter 12, chapter 19 for ICD-10 in this book, but you do know where to go to look for codes in reference to the integumentary system. What does that mean? You're going to have 10 questions from integumentary. Your physiology and your anatomy is going to be covered towards the back, right? But you still want to have them grouped in the sections. But you also need to know, where am I going to find ICD-10 codes in reference to integumentary? So it tells you here that those answers are going to come from chapter 2, chapter 12, chapter 19, right? Well, chapter 19 is basically going to be in the majority of all of the body systems, because those are injuries and poisoning, and that injury and poisoning can happen to any body system. So chapter 19 is always going to be part of the different body systems. But what I do know, I'm looking at this slide, I'm like, okay, chapter 2, that means I need to make sure I understand how to code neoplasms, right? And then chapter 12, which I believe those begin with L's for the skin, L. So you think about neoplasm. Is your neoplasm table tapped? Do you know how to maneuver through the neoplasm table? Do you understand the headers that are involved with the neoplasm table? These are things that you are going to have to do to make sure you're understanding, right? And as you can see, chapter 12 is for skin infections, corns, calluses, you know we're going to code all of that with integumentary. Then you have inflammation conditions of the skin, pressure ulcers, right? Also need to make sure, look, let me go back up. Let's go through these page by page first. Okay, well, the pressure ulcers aren't in the beginning. It's towards the back, I believe, for pressure ulcers. Let me find that page. Because your pressure ulcers are on page 89. Right? That might be something I might even jot in my book under my need to knows. I know I've given you some, but we're going through the slides. So if we pick up additional information that's going to help us, you're going to put it there, right? So decubitus ulcer is telling you, where do I need to go? For pressure ulcers, you need to go to page 89. And when I'm there, what am I looking for? You need to identify where the ulcer is and what stage the ulcer is when you're coding for pressure ulcers, right? You need to know the location and the stage. Okay. Wounds, sometimes, and this is great that we're actually doing this tonight because we can break down some verbiage and make them make sense, to you. Wounds they have listed under injuries and poisonings, right? So let's see. You could see sometimes under wounds, even though you're looking up wounds, the term they may place in the question may just say open wound or lacerations or punctures, open bites. See, these are also known as, that fall under the category of wounds, right? Corrosions are chemicals, and burns, and they're like what is considered burns, anything that happens from fire, heat source, or a hot appliance. When you're coding for burns, this is in reference to ICD-10, guys. When you're coding for burns, what do you look for? When you're coding for burns in ICD-10, you need to know the location, the severity of the burn, and the total body surface area that's involved. And you also want to capture the total body surface area if there's any third degree, if there's a third degree burn. And remember, the highest severity goes first. So if you're noticing that the patient has multiple burns, you're going to say, okay, which one was third degree? Because I know that needs to go first as far as my sequencing, right? So you'd have third degree, second degree, and then your first degree. Right? So your first degree, what's a first degree burn? A first degree burn is like a sunburn, right? Second degree is like you're standing in front of the stove and you're frying something and some of the oil gets on your skin and now you have a boil, right? It didn't totally erupt, but it's there, and that's considered to be second degree. Third degree, it has broken through the skin and sometimes the nerves are exposed and also the muscle, possibly even the bone. So of course that's going to be the most severe out of the three. So as far as sequencing, my third degree burn would be listed first. Okay. And also remember, any procedures that are performed on the breast also fall into the integumentary system, as the breast is considered part of hair, skin, and nails section, the integumentary section. Okay. So now we're getting into our CPT ICD-10. Get back here. So right now I'm on page 71 in your CPT book. Okay. Page 71. And just remember, I have sent you all the need to knows. So you need to make sure that you can pull those up. Those should be filed. And with your need to knows, those should be written on page 70. Your need to knows need to be written on page 70. I'm going to run through them really quick. Okay, so you would have adjacent tissue transfers. In my head, I'm asking you, well, I'm actually asking you out loud, but adjacent tissue transfers, you're going to find that on page 82. Benign and malignant lesions are going to be on page 75, 76. Then I also spoke about breast augmentation. That's going to be found on page 93 through 97. Your mastectomy procedures, and basically, mastectomy is also found on page 70 in the on the reference page. Also, mastectomies are found on page 96. Lacerations, 79. And as I'm saying these terms, you kind of have to think in your head, what's the concept to code for this particular procedure? Like when I say lacerations. When I think lacerations, I'm always thinking simple, intermediate, complex. Remember, if they're in the same location or if they fall in the same category and they are the same complexity, then you can add those together. If they are different complexities in the same location, right? Different complexities, same location, then they have to be listed separately, right? Fine needle aspiration can be found either on page 71 or 92. Pilonidal cyst, page 78. Mohs micrographic surgery. Definitely know they're going to ask you a question on Mohs micrographic surgery, my favorite. Rotation flaps on page 86. Okay. We just spoke about pressure ulcers. That's going to be on page 89. Herniated fat pad. What am I talking about? Blepharoplasty, the drooping eyelids. That's found on page 88. Debridement, page 72. Procedures on your breast, such as a biopsy, page 97. Split thickness grafts, where are we going to find that? Starting on page 84. In the integumentary system, modifier 58 is a common modifier, right? Remember, modifier 58 is staged. And 78, unplanned return, is another common one. Wart removals, found on page 91. And your burns, we're talking about page 9, how to code for burns, and modifier 58 and 78. We said that already. And anything else? Nope. And that's it on that, on your need to knows. Now, back to page 71. Under the skin, subcutaneous and accessory accessory structures, incision and drainage, right? So we're looking at page 71 right now. And we're looking under the incision and drainage section. So your red is your category, which is skin, subcutaneous, and accessory sinuses. And then what are we doing in that category? Incision and drainage. So these are procedures on the skin, subcutaneous, and accessory sinuses. And incision and drainage is one. Now on the slide, main thing you need to remember, right, is whether it is simple or complicated. Simple or complicated. How do we know if it's simple or complicated? Well, complicated, we should have written in our books somewhere, because you need to know what simple and complicated is. I would even write it complicated at the top, maybe, or complicated if you can fit it somewhere next to incision and drainage, but I need to know what complicated means. Complicated is if a drain is involved, is replacing a drain. Okay. Is there any type of infection? Hemorrhaging, yes, hello, that makes it complicated. Hemorrhaging that requires ligation and takes a lot of time or extensive time to treat or to perform the incision and drainage. All those terms makes your selection complicated. So it's important that you understand what complicated means, right? I do believe that you guys have hemorrhaging, extensive time, the drains, and infection. Right, so those are the main things there that you need to make sure you understand, because you may have a question that comes from the incision and drainage section in Integumentary, and you're going to need to determine whether it's simple or complicated. For example, CPT code 10080 and 10081. Okay. Those are two examples, right? And remember, this is incision and drainage. It's not excision. Okay. Because if it's excision, then we're going to a different category. If you look right under CPT code 10081, it says for excision C11770 through 11772. Excision, we're actually removing something, taking a piece out. Incision and drainage, they're just going to puncture and then drain whatever yummy stuff is inside. Alrighty. On debridement. Debridement, we're moving on to page 72. Page 72. And so when you're coding for debridement, you have to think about the method for removing the dead tissue. The debridement is they're cleaning that tissue from the infected skin. Okay. What do I need to know for debridement is how much of the body area is being debrided or debrided. Tomato, I'm not sure. But you need to know the amount of the body area. Okay. So if you're looking on page 72, right now, we could look at CPT code 11000 and see that's 10% of the body surface, right? And then CPT code 11001 is each additional 10%, each additional. So if it was 30%, you'd have CPT 11000 and then 11001 times 2, right? Also make sure, okay, so you got the body surface area. I mean, you are questioning how much of the body surface is involved, right? See that there? And then if you go on down to 11004, then it starts to discuss the actual body areas, Okay. So debridement is going to be covered on page 72 and 73 of your CPT. Okay. And if you're on page 73, if you look at CPT code 11010, make sure you can highlight there where it says foreign material. Okay. And the site of an open fracture. Okay. CPT code 11011. What stands out there is the muscle, right? And CPT code 11012 is muscle and the bone. So of course now on page 73, I'm like, what's the depth? How far am I going? Okay, how far? Okay. And remember the pairing and cutting. Next to pairing and cutting, you should have how many? Next to pairing and cutting, you should have how many, meaning how many corns are being removed. CPT code 11055 is only for one lesion. 11056, 2 to 4, and 11057 is more than 4. So you're asking yourself how many lesions are being removed in the pairing and cutting section. And then we move on to biopsies. Biopsy starts at the bottom of 73. Biopsy start at the bottom of 73 and continue on to 74. Okay. And this was the fun one when we started to do all the calculations, right? So remember, when we're talking about biopsies of lesions, we need to know if the lesion is benign or malignant, right? Then we need to know where the lesion is, what's the location, and then we also need to know the size. Okay. And remember that there is a formula for measuring your lesion removal, and that is to double your margin and then add it to the lesion excised. So for example, on page 75, example A, the lesion excised, the lesion is the melanoma in example A on page 75, and the melanoma is 1.0. And I said, you need to double your margin, so you need to know what your margin is. And it tells you that your margin is 2.0, right? So if I'm going to double my margin, that's going to be 2.0 plus 2.0. You have 4.0. And then add it to the lesion excised. My lesion is 1.0. Then my total is 5.0 centimeters. Now I need to know, because I did my calculation, I have my number. I've jotted my number down to the side. Now I'm like, where's the location? Where is it? Right? And is it benign or malignant? And in example A, it tells you it's malignant and that your size is 5.0 and that the location is the back, right? So you have your benign lesions listed on page 75 and 76, and then your malignant lesions listed on page 77 and 78, right? And they said malignant, so I already know malignant. Okay, that means I'm turning to page 77. I'm looking for my location. My location is going to be the back. And then I'm looking for my size, and the size was 5.0. And that should have you result with 11606. 11606, right? The back is part of the trunk. Is also considered the trunk. Just don't forget that. And sometimes they may not say malignant, right? So you need to know that a basal cell and a squamous cell and a melanoma is also considered to be malignant. What? I know somebody's like, I didn't get that. All right, let me put the malignant ones in the chat box. That's basal cell, squamous cell, and a melanoma is considered, I spelled that one right, melanoma, is considered to be malignant. Right? And then as far as, remember, you don't have to get confused on the formula. The formula is located on top of page 75. You are going to double your margin and then add it to the lesion excised. And then what are you going to do? Then you're going to find out whether it's benign or malignant. You already have your size, and then the location. Where is it? The face, the back, you need to know. And there you will be able to get your answer. Okay? So that's in reference to the lesion removals. All right, here it is. On the excision of lesions. You got your measurement there. How do you select your code? Whether it's benign or malignant, you need your size in centimeters, and then you need to know the location. On the nails, we're not going to go crazy over the nails because you just need to know how many are being debrided or trimmed, which is on page 78. The nails, page 78. And you just need to know how many for the trimming. And if it's debridement, then you can look at CPT code 11720. And just also you need to know the amount, okay, for the nails. So it's either fingernails and toenails or they're doing the trimming and debridement. The pilonidal cyst, which is at the bottom of page 78. Remember, you need to know the difference between simple, extensive, and complicated. Okay, if you don't have that written on page 78, simple, because they don't have it up here on the slide, but I like to give you that information. Simple is going to be that they just excised the cyst and then they sutured. Okay, extensive, meaning it was larger than 2 centimeters, and complicated, meaning it's extensive but surgery is required. Okay. In reference to the pilonidal cyst. Then we move on to page 79 for the repairs. Look, it gives you, this is when we start to talk about lacerations, right? Lacerations, whether it's simple, intermediate, and complex. The definitions have been provided for you on page 79 for simple, intermediate, and complex. Okay. So, and what you should have highlighted, simple repair, the wound is superficial, right? And it requires a simple one-layer closure. So it is a layered closure, but it's one-layer closure in the simple repair. Okay. In an intermediate repair, it is required layered closure. Okay. And they will talk about extensive cleaning when it's intermediate. And with complex, it's more than a layered closure. Okay. They may even have to involve stents and sutures. But again, this is not something that you're going to have to memorize. It's all located on page 79. Okay. But when you are coding for lacerations, the 3 important factors that you need to remember is how big is the wound? Now, what's the size of the centimeters, right? The complexity, whether it's simple, intermediate, or complex, and the location. Okay. And the location. And remember, as far as sequencing, the most severe, simple, intermediate, complex, meaning complex, is going to be listed first as far as your sequencing, okay, for your lacerations. So on page 80, what I did, next to where it says repair simple, just write superficial there. Where it says repair intermediate, write layered closure. Where it says repaired complex on page 81, put more than stents. So you already have them categorized as far as what the closure would be. All right. Page 82. Page 82, this is when we start talking about those flaps, right? Remember, if there is a lesion, I'm going to say it one time. If there is a lesion excision and there is also a flap repair, right? Remember your flaps start 140, somewhere around there. You do not code for the excision of the lesion. You will code only the flap. You're going to code only the flap. Okay. As far as your, so on page 82, you should automatically have written at the top, code only the flap. Okay. Remember, we were also talking about if they have to surgically prepare the site, okay, or if they're going to have skin replacement surgery, that code range 15002 through 15005. And it's going to be based on the size and the location. So make sure that you read that in your PMCC for underneath your integumentary section. Okay. Moving on to where it says repairs. Okay, those are all flaps on page 86. On page 87, that's in reference to the graphs. On page 89, make sure, because I had suction-assisted lipectomy on my need to know, that's CPT code 15876. And you have to pay attention to the location, whether it's going to be the head, the neck, or whether it's going to be the trunk, which is usually where they do the liposuction, 15877. Okay. I'm on page 91 under destruction, because under the repair is where the liposuction fell. And you can see these are all just like procedures that are performed on the skin, right? Dermabrasion, chemical peels, blepharoplasty, that's the drooping eyelids, abdominoplasty, right? Tummy tuck, liposuction, they're sucking out the fat. Under destruction, which is on page 91 in your CPT, remember destruction, they're going to be using some type of device. When you hear the word destruction, I want you to think of the term device, because they're using a device to destroy either a wart, a skin tag, a lesion. That's what destruction means. So as soon as I see destroy, I'm going to look for destruction. Patient came in to have 5 warts destroyed, right? So that means destruction. And I'm thinking to myself, what is going to be the method of destruction? Here you can see laser treatment, chemical treatment, cryosurgery, electrosurgery. Those are the methods of destruction. Okay. And on this page, on page 91, you're still going to decide whether we used to look and see if it was malignant or benign, but on page 91, you're trying to see if it's benign or pre-malignant, right? Benign or pre-malignant. Okay. And I think it was page 91 under destruction where it gives you a little overview and a definition. In that second paragraph, it gave you a description of the benign lesion and the pre-malignant lesion. So you can highlight that section there. And as you can see, CPT code 17000 is for your pre-malignant lesions. And then you drop down to CPT code 17110, and you'll see that those are benign lesions. So on page 92, you can also see that's malignant lesions there. And so you're just looking for the number of lesions that are being destroyed and whether they are benign or pre-malignant lesions. And make sure you pay attention to the location. Okay. Mohs micrographic surgery, which is on it gives you a little overview of what Mohs micrographic surgery is all about. Remember, that's that special microscope where you're able to excise maybe a wart, and you want to see if it's cancerous and how far the cancer has invaded. They'll take that one specimen, place it on the Mohs microscope, and it's going to take like an electric laser knife, and it's going to slice it by layers and place it into the blocks. And a complete block is called a stage. I feel like I'm playing some type of game show. But remember, the complete block is a stage, and a stage has how many blocks? 5, right? Has 5 blocks. So with that, you're looking for the location. If you look at CPT code 17311, that's going to cover your head, your neck, your hands, your feet, and the genitalia. CPT code 17313 is going to cover the trunk, the arms, and the legs. And underneath both of those categories, you'll see there is an add-on code for additional stages. So if they say second stage, you would be using that plus sign, the code with the plus sign, right? And if they say, remember, each stage has 5 blocks. So if they say in the first stage there were 6 blocks, then you're going to need to take a code from your additional blocks. And what code is that going to be? That's going to be CPT code 17315. Okay, as far as your Mohs micrographic surgery. Right? And the last thing that we cover in the integumentary section are going to be procedures on the breast. Procedures on the breast. Okay. So for procedures on the breast, you could always go back to your reference page, or you can just look at the various categories. On page 93 and 94, it gives you definitions of the various types of biopsies and mastectomies. You can see what's involved in it, and also the code range for the different procedures on the breast on page 93 and 94. Okay. All right, and on page 94 under CPT code 19083, make sure you have highlighted where it says ultrasound guidance, which is at the end of the definition. And with CPT code 19085, make sure that you highlight where it says MRI. That's for MRI guidance. One was ultrasound guidance, the other was MRI. So when it's time to talk about coding for a biopsy on the breast, and they're placing like a localization device, in order for them to place that device, they have to have some kind of guidance. And so you will be looking to see whether it is ultrasound guidance or magnetic resonance imaging, MRI. Okay. Same thing on page 95, CPT code 19283. At the end, it's going to be stereotactic guidance. Go up 2 code, CPT code 19281. That's mammographic guidance. Come on down to CPT code 19285, ultrasound guidance. So of course, on these breast procedures, what are you going to be looking for? If they're placing markers, you're going to need to know the type of guidance, right? And as you can see, there's various kinds. Let's see, and that's it on the breast. Let's see what else they have here. And we just spoke about that, mastectomies, the repair reconstruction. A mastopexy is actually a breast lift, and then you have your breast reduction. All right. Before I move on to musculoskeletal, let me just stop this for a second. No, I'm going to let it roll. Does anybody have any other questions in reference to the integumentary system? Let me open the line. Just wanted to make sure everybody was at least comfortable or could relate to everything that I just discussed. Nothing should have sounded foreign to you. And if it did, if there was a particular term that you were not comfortable with, or you're like, what is she talking about? Remember, you do have your textbook to reinforce it before we meet again. Okay, so that was just integumentary. See. So what I'm going to do is go through musculoskeletal and then the 30,000s, and that's where we'll stop because I did the other part. And then when we meet again next week, Wednesday, then we can complete the other ones. Is that so? Because I don't want to hold you guys up the whole night, but I do want to make sure that I'm kind of reintroducing this material to you, making sure that you're comfortable with it. Everyone comfortable so far?
Yeah.
All
Yes.
right, good. So when I was talking, you were like, yeah, I remember that. Yeah. Got that, right? Okay, perfect. I'm glad. All right, so let's move on to musculoskeletal. Now remember, my tips to you on musculoskeletal is not to get paranoid over this particular section because the codes are so different as far as what the definitions are, right? They're really not that close. And the answer is there. It is multiple choice, but we're going to talk about some of the main procedures in the musculoskeletal system. Make sure you understand them, and then we can move on. So with musculoskeletal, so with the skin, there wasn't too much to jot down, but I will tell you with musculoskeletal, please make sure you know the difference of your axial and appendicular skeleton. You need to know the parts of the axial skeleton and the parts of the appendicular skeleton. Okay. So make sure you understand that. Axial, appendicular, you could just be making little notes right now. I need to know the parts. Write those in your book. If you're not sure of what they are, you have a diagram on page 99, and you could highlight what part is axial and what part is appendicular. You can color code it, make it easy for you. Right? A is red and orange is the bottom part. You know what I mean? Just think of a way to color code it to make it easier for you to understand when you get to that page, how the skeleton is actually divided. Ligaments attach bones to other bones, tendons, muscles to bone, and cartilage is like the cushion in between. Like it's like the hinge, right? All right. With musculoskeletal, as far as your ICD-10, this is where you're going to have a lot of, I like it because you're going to have laterality, so you can look for left or right, or if it's both sides, right? And if they don't have a code for left or right, then you will, if they don't have a code for bilateral, I should say, if they don't have a digit to specify bilateral and it was left and right side, then you should write those, the code out for right and then a code out for left. All right. Okay, these are just some of the diseases for chapter 13. Pathy, right, is pathology, and arthro, they're describing, arthro means joint. Okay. Dorsopathies are pertaining to the spinal cord, and bursitis is inflammation of the bursa, itis meaning inflammation of. And remember that there's different types of fractures. Okay, different types of fractures. Those are also discussed in your PMCC text. And with the musculoskeletal system, just like the nervous system, to me, because they're talking about all the different bones, and in the nervous system, of course, all the nerves with the skull, and then in spinal cord, and then in the nerves. But in musculoskeletal system, the reason I'm bringing this to your attention is because I like to use the reference pages for those two particular sections, for the musculoskeletal system and also for the nervous system. Why? Because it's so detailed, it's easier to go to your reference page and to look for the body part. I like that. If I know they're getting ready to do a repair, a fracture repair on my skull, I know I can look at the reference page and say, okay, I need to look for head, right? Because that's where your skull is located. And that's what you also have to keep in mind as we go through each of the chapters and each of the different body systems. I'm going to keep drilling this into your head. What body part are they working on, and what are they getting ready to do to that body part? Because once you can find those two objectives in your question, you're halfway there. Because now you know where you are, and now I know what they're about to do to it, right? And then you're just reading the question for additional detail to drill down your CPT. So if you're looking at page 99, you can see in the reds, that's my body parts, right? So you got head here. If you turn to 100, you'll see neck, back and flank. Page 101, the spine, abdomen, shoulder, humerus, forearm. 102, do you see what I'm saying? They've broken it down by body part. So now if I say patient's coming in to have a cast applied to his leg, then you can look through your reference pages and say, okay, applications and casts, and now I'm going to lower extremities, and what are they getting applied? I said a cast, so the only option for you to go to is page 164. Right? So that's why I'm like, when you're reading your question, you got to look and see a couple of things. First of all, what do they have as far as your diagnosis, if you're going to need to capture that? And as far as the procedure, what part of that body system is the procedure going to be performed on? And what are they getting ready to do to that body part? That's what's important with musculoskeletal, right? They talk about the different treatments of the fractures on page 104 in your CPT. They have definitions there as closed treatment, open treatment, percutaneous. Make sure you read through those or highlight them so they stand out. On page 105, it's going to talk about radical resections of tumors, right? Those are tumors. And remember, anytime they talk about radical, if a procedure is performed and it's radical, usually there are lymph nodes involved. There are lymph nodes involved. On page 105, I am looking under wound exploration, which is on page 105. And there you see the type of fracture treatments. Remember, I will be sending this to you. And you also have it. You also have the PowerPoint. So on the wound exploration, this is going to be in reference to like gunshot wounds. I already have gunshot highlighted there. With this particular section, you just want to know the location of the wound. If you look at CPT code 20100, location is neck, 101 is chest, 102 is either the flank or the back, or you can also say trunk, right? Trunk and back. And CPT code 20103 is the arms or the legs. So basically, where did the trauma occur? So it had to have penetrated, because if not, it's just going to be on the skin, and then that's going to take you back to the integumentary system. Same thing under your general heading, you have your excision and biopsies. And they talk about with excision and biopsy, how far are they going? Because now we're done with the skin. That's integumentary. Now we're looking to see, are they going to the muscle or to the bone? Because this is musculoskeletal, right? Muscles and bones. Okay. And then how wide or how large is the wound? Okay. And also maybe even the location, or whether it's open or closed, are also things. Trigger point injections, I'm pretty sure you'll get a question on that. That's also on page 106. Page 106, CPT code 20552 is through 20555 are trigger point injections. Here's the difference. CPT code 20555, CPT code 20555 is also a trigger point injection, but it's at the same time as a major procedure, right? So 20555, it's happening with a procedure. Okay? And so the other two that I listed above, the other injections, those are performed independently, right? Not along with another procedure. 20555 is performed with another surgical procedure. Okay. On page 107 is going to be your arthrocentesis, which means withdrawal of fluid through the joint. Right? So you need to identify what that joint is. 20600 is the small joint. 20605 intermediate. 20610 major. And so you have to make sure you pay attention to that. As a matter of fact, I think I may have to stop after musculoskeletal. Let's see. What else? Page 108. That's the halo application. What's important? CPT code 20670. Do you notice it says separate procedure there at the end of that definition for the removal of the implant? So that means it's a procedure that's usually performed by itself, right? And if it does happen to be performed with something else, make sure that you tack on modifier 59. Modifier 59. Okay. And then on page 109, you could see these are external fixation device procedures. External fixation. Let's see where else we're going through. And then they talk about procedures on the spine. So this is the spinal column. But you'll also are going to revisit these type of services again in the nervous system, because they'll be doing the same procedures, but on nerves, which is more delicate. So your C stands for cervical, T for thoracic, and L for lumbar. And remember, usually they'll have L5, S1, and S1 is the first area in the sacral area. And you need to make sure you read the definition for segmental and non-segmental, right? In reference for the musculoskeletal system. Right now I'm on page 117. 117. On page 117, wherever you see back, you'll see back and flank, and then you'll see on page 116 it has neck, These are locations for tumors, right? So these are tumors. So you might want to write tumor next to those. Those are tumors. And then on page 120, these are fracture or dislocation. And remember in ICD-10, if the patient has a dislocation and a fracture, you're only going to code the fracture, not the dislocation. The dislocation is part of the process of that fracture. So then you don't, code both of them. You'd code the extent, and that would be the fracture. Okay. On page 121, it's still talking about procedures on the vertebral column. Okay. See what else? I think that's it. Oh no, spinal instrumentation. I think I said to make sure that you read the definitions. Those are located on page 125. The definitions are actually in your book on page 125 under spinal instrumentation. Okay. L5S1. Amputations are also important. That's found on page 131. Amputation. And also on page 135, amputation. Page 136, they talk about the injections there of the wrist. CPT code 25246. CPT code 25246. All right. And then on page 143, this is code. So basically, just to summarize how the musculoskeletal system works, because I didn't go page by page, because what they're doing, they're breaking it down by body section, and they're doing the same procedures, but for each of the body sections, right? So you can go to vertebra, and then you can go to fractures of the vertebrae, right? Or you could look at hand and fingers, and they'll go, fractures of the hand and fingers. So they're all broken down, the same procedures, just on different parts of the musculoskeletal system. That's why it's important for you to understand what the body part is and what they're getting ready to do to that body part. Because once you understand that in the musculoskeletal system, it's going to be super easy, because it's going to take you right to the page where you need to go to obtain your answers. And we'll get a little deeper. Again, this is just kind of like a review. Remember this, remember that, for these sections, and we'll really drill down when we get into the boot camp. So I just wanted to expose you again. I was telling you on page 143, make sure you're paying attention to the bone that these procedures are being performed on. For example, CPT code 26607, it's a metacarpal fracture, right? But then you jump all the way down to 26670, and it's a carpometacarpal dislocation, right? So just make sure you're paying attention to the terms and the spelling of the words. You turn over to page 144. These are all going to be procedures on the pelvis and hips. So they started from the top of the bones, and now they're moving down. And with the pelvis and hip, you can see they go excision, introduction, removal, repair. And then on page 147, they conclude with fractures and dislocation. Same thing, turn to page 149. Now they're talking about the femur, right? Excision. Turn over to 150, it says introduction, removal, then you have repair. And then you look at page 152, same thing, fracture, dislocation. So basically what you did was just found the body part and what they're getting ready to do to that body part, if it's making more sense to you. Page 153, same thing, leg. Now we're talking about the leg and the ankle. You turn the page, same thing. On page 155, they end with fracture dislocation. So as you can see, page 157, we're now at the end, at the toes, right? We started at the head and we worked our way all the way down to the toes as far as bones and muscles. So on page 157, we're ending with the foot and the toes. Turn your page to 158, repairs and revisions. So you can, on page 160, 161, these are all the different procedures on the feet. And then once you get to page 162, you see they're ending with the fracture and dislocation. Same process, just different bones, right? They started from the top and they're doing the same thing for all of the procedures all the way down to the toes. Okay? And then it ends the musculoskeletal system. It should end with your cast and your strapping applications and snap, right? And as far as your need to knows for the musculoskeletal system, let's see where we are with time, 8:17. I think I can do the 30,000s in 10 minutes. That won't take long. All right, so you have your trigger point injections. Remember, you should have your need to knows already written in your book. I should just be repeating these, and you should just be like, yep, got it. So you got trigger point injections that can be found on page 107. Surgical arthroscopy, you can go to the index for that, or you can go to page 160. Make sure you understand your fractures. Make sure you understand your fractures. Remember, you have to know the name of the bone, whether it's open or closed, and whether it's with or without manipulation. That's going to be important in your CPT portion. Your injections. If you're looking for injections, you're going to go under introduction because an injection is introducing the needle. Make sure you understand the definitions of manipulation and reduction, which is basically the same. Lipomas are also called tumors, right? We just spoke about that. Those start on page 116 in your CPT. And when you're coding for lipomas or tumors, make sure you pay attention to the location and also to the size. Vertebroplasty is on page 120. Common procedure. That's a repair of the vertebra, plasty, surgical repair. Fluoroscopic guidance is going to be back in the index on page 854. ORIF, open reduction internal fixation. Those are found on page 852 I have there. Tendon repair. You need to know the part that's being repaired and the actual action. How are they repairing it? The rotting, intermedullary rotting is on page 104. We just spoke about amputation, reamputation. That's on page 131 and 144. When you're coding for discectomy, remember we were talking about cervical, thoracic, and lumbar. Those are the discs, those little interspaces in between are considered interspaces. A common procedure performed on that area is called a discectomy, right? And you just need to know the location, what range. Is it in cervical, thoracic, or lumbar? You can actually go to discectomy on page 826 in the index and then just look for your location. Spinal instrumentation is defined on page 125. And we spoke about wound exploration and also sequestrectomy. Woo, that's found on page 962. How do you spell that? SEQUESTRECTOMY. Yes, I will put that in the chat box. Just make sure you have it. It should already be in your need to knows. Hope I spelled that correctly. I think I did. Yeah. So that is that on musculoskeletal. Just a little recap to wake you guys up, get you back in the CPT world. All right. HCPCS, we already spoke about that. Just make sure you're paying attention to how to look everything up in the index. I think I'm going to stop after after this little section here. This was an easy section though. The 30,000s was really easy. I don't know if anyone has questions on that. I know no one ever, I always say no one does bad in this section on the exam in the 30,000s, because the 30,000s are going to be talking about respiratory, right? That's when you have to pay attention if it's bilateral or unilateral. Let's look at some of the things they have here on this slide. Okay. So remember, respiratory system is going to be, I'm on page 171 right now in the CPT, but your respiratory is going to cover your nose, accessory sinuses, your larynx, trachea, and your lungs. Very, very short, that particular area. And again, just like I said with the musculoskeletal, it's set up the same way, guys. You got to understand how they're working this so you know how to tear apart your questions, how to tear your questions apart. When I'm on the respiratory side, there's going to be 10 questions, right? And it's going to come from what you see listed here: respiratory, hemic, lymphatic, mediastinum, and diaphragm. And they'll maybe even throw in a few are cardio. And I don't want to go into cardio now. I'll do that next week with you guys. But again, what's my body part? What are they getting ready to perform? What are they getting ready to do to this body part? So I know what page to go to. We don't have a lot of time. We only have 2 minutes each question, right? So you need to be able to abstract the information that's necessary for you to assign your code. And so respiratory system here, I like that it gave me the little function of the alveoli. Alveoli, remember those are like the grapes at the end of the bunch, right? You have your bronchus, your bronchioles, and the alveoli. Right? So alveoli are located at the ends of the bronchioles. Right? What's their function? For they exchange carbon dioxide and oxygen. Okay. See what else we need to know about respiratory. And this is just basically just giving you like an overview of the various functions of these systems. You have hemic and lymphatic, what the spleen does. It's located on the left side of the stomach. It's a reservoir for blood cells, and it produces lymphocytes. See, if I didn't know that, I want to have that somewhere. I just need to know what the spleen does. I need to have a little capture somewhere in that section. Because you never know as far as the anatomy and physiology what they're going to ask you for each of those body systems. So if you can have a few tips written here and there, it's going to help you along the way. Let me see what I have in here. All right, I'm on page 173. Page 173 in my CPT, and I can see here it starts with procedures on the nose. Right? And instead of looking through these pages, you could always flip back and say, okay, flip back to page 171. Keep your finger there. There you can see the first section. There's only 1, 2, 3, 4, 5, 6, 7 different things that can be done to what? The nose. So now in my question, I'm like, okay, I'm looking for these keywords in my question. For the most part, they'll say incise or excision, right? They'll use these. Came in to have a catheter placement. Well, if it's a catheter, it's being introduced, right? Removal of foreign body. Okay, so they may not say foreign body in the sentence. Your foreign body may have a name. It may be a penny. It could be a pebble. It could be a little rock. That's a foreign body, right? So they don't have to physically say foreign body. It doesn't belong there. That's why it's considered a foreign body. So if you know a penny doesn't belong in the nose or a marble doesn't belong in the nose, it's considered a foreign body. Right? Or you can have a repair. Once they say plasty, right? Rhinoplasty, that is a surgical repair of the nose. Or destruction, right? They may not say destruction. They may say destroy. Right? So you know to look for destruction. And then they have, let's see what they have listed under other procedures. So you can kind of see what I'm doing, how I'm breaking it down, and how you should be looking in your question. I know next week what I'm going to do is have some sample questions up so you can see how we're pulling out these terms. What was I looking for? Okay. Oh, other procedures is what I was looking at. Let's see. So under other procedures, which is on page 188, it just basically talks about total lung. So there's only 3 things here. Unlisted, ablation therapy. Under CPT code 32998, I want you to underline plural, where it says pleura or chest wall, because this is where they come to destroy or ablate tumors that are located on the chest or in the pleura area. So these are for pleura tumors. Yeah. Under other procedures. And cardio, I said I was leaving until next week. So this section is very, very short. I just want to look at a couple of things again. I want you to go back and look at page 171. I want you to get comfortable. Someone just asked if they're getting any more practice questions. I don't have any more practice questions unless you just want me to create something and send it to you. Also, remember that you also have the practice exam that's on the AAPC website. Have you guys been using that? Because the AAPC practice exam that's available to you when you log into the AAPC website is also timed, right? And those questions, some people say they're very similar to what you're going to see. So if you just want blank tests, if you just want me to create something for you, I can do that. But they're basically going to be questions you've seen already. And I want you to test yourself. Yeah, I want you to test yourself on different variations, but within the same body system. You know what I mean? So from a different source. Remember, there's also, gosh, what's the name of that website? There's a couple of websites I have to think of where you can go on and you can just actually do a practice quiz. JustCoding.com. JustCoding.com has a free area. EM University has a free area to help you on the E&M sections, but justcoding.com is great because they have like just 5 questions, right? You can just do 5 and click your answers in each of the body systems just to make sure you're getting it and you're understanding, and you're not just seeing the same things within Chronicles classroom, because they'll have different versions or different questions for you to go through. But do remember that you do have that practice exam on the AAPC's website. On the AAPC's website, it's timed, and it will also give you a rationale.